we're going to talk about the clinical pathobiology of Alopecia areata. Before we do that, let me introduce myself. My name is Ralph Paus. I'm a professor of dermatology at the Department of Dermatology and Cutaneous Surgery at the University of Miami, Miller School of Medicine in Miami. And I'm also a professor of cutaneous medicine at the Center for Dermatology Research at the University of Manchester. In addition, I'm editor of one of Europe's leading skin research journals, Experimental Dermatology, and I have some disclosures, none of which I think are relevant for this presentation. Now, alopecia areata is not only one of the most common human autoimmune and autoinflammatory diseases, but it's also one of the most fascinating ones. Here you can watch immunology and immune responses in the skin while they happen, and you see whether your therapeutic intervention as a physician has actually managed to restore the immune physiology of a wonderful human model mini organ, the hair follicle. Alopecia areata also holds numerous immunology lessons in store. It's a teacher of clinical immunology, if you wish, that may be transferable to other, much less accessible autoimmune diseases, such as multiple sclerosis, autoimmune uveitis, fetal immune abortion, and many others that share similarities with what happens in alopecia areata. It's also an exemplary testing ground for new immunopharmacological intervention strategies that you can observe in this organ that is totally accessible to the naked eye, whether your intervention has actually worked. Now, hair growth disorders come in many shapes and colors and can be confusing, but it's actually quite simple. You can recognize in all hair growth disorders 5 main hair pathobiology principles in this case. The most important that basically all of the most common hair growth disorders you see in clinical practice share is that they are all disorders of hair follicle cycling. Now we'll come back to that mysterious hair follicle cycling affair in a second. Then there are, of course, very famous hair growth disorders that not only have a hair cycling abnormality, but which also transform the hair follicle from a large terminal hair follicle into a tiny little vellus hair follicle. That's androgenetic alopecia, which is both a hair cycling disorder and a hair transformation disorder. And then there are structural hair shaft disorders, most of which are acquired actually during what you do to yourself, to your hair. Genetic hair shaft disorders are a rarity. And then there are stem cell defects leading to scarring alopecia. And these stem cell defects occur because the hair follicle loses, in this case, in the stem cell area, the bulge, its so-called immune privilege. Now, the collapse of the hair follicle's immune privilege, and we're going to get into details in a minute, also apply and lie at the heart of alopecia areata and its pathobiology. Alopecia areata, therefore, not only is a hair cycling disorder, it's also primarily an immune privilege defect. And as a result of all that, you also get a hair shaft disorder. The hair becomes structurally impaired. So if you keep these 5 pathobiology principles in mind, you can apply them basically to all hair growth disorders. And alopecia areata is a wonderful example because it touches on 3 of those. Now, the learning outcomes, after we're done, will be the following. And bear with me here. So first of all, we want to understand together what is immunologically so special about the hair follicle. What is the underlying pathobiology of alopecia areata? And namely, why do these pathobiology elements play such a key role? Collapse of the immune privilege that I keep going on about, hair follicle dystrophy, so damage to the hair follicle so that it cannot retain its hair shaft properly anymore, and premature induction of the regression phase of the hair cycle called catagen. You also hopefully will have understood by the end of my presentation which therapeutic intervention target these key pathology principles most efficiently, and what are the associated problems or concerns that the therapies we are currently using raise. And what drugs do we still need to develop to become even more effective in targeting the core pathobiology of alopecia areata? Then I would like to introduce you to a concept that we have recently proposed, which is a bit heretic. I claim that alopecia areata is not even a disease entity as such, that it is rather only a stereotypic hair follicle response pattern to immunological damage, which even the most healthiest hair follicle will show if it suffers a certain type of immunological damage and immune privilege collapse, which can be triggered by at least two different, very distinct pathways, namely a classical autoimmune pathway, which I then would call autoimmune alopecia areata, AAA if you wish, and a non-specific auto-inflammatory pathway, auto-inflammatory alopecia areata, AIAA. Now, and finally, I would hope that you will understand in this lecture why we really need a much more personalized medicine approach to future alopecia areata management that distinguishes between these subtypes of areata. For any dermatologist, diagnosing alopecia areata is not the difficult issue. Diagnosing it is quite easy because it shows almost pathognomonic signs. Here you see a father with just a little bit of focal alopecia in his beard and his much more severely affected daughter. So it's easy to diagnose. You only have to consider whether you're doing this right, and you also have to consider some difficult differential diagnosis and how to assess the prognosis of the patient in front of you. That, however, is not the main topic of our pathobiology-focused presentation today. Now, areata, as you already see in this image here, comes in very different phenotypes. Now, what does that really tell us? Actually, the phenotypic difference is not the main reason why I say they are very different pathways leading to alopecia areata. The problem is that the phenotype we look at does not tell us how the disease began. But we already know from data that I will present to you that alopecia areata is not always a classical autoantigen dependent, autoreactive T-cell dependent autoimmune disease. Now, areata is also very challenging for the practicing physician because both the patients often are very frustrated and can be quite demanding, and the physicians also, until recently, have long been frustrated by this disease because we didn't really have very powerful pharmacological tools in our hand until the event of JAK inhibitors, which we will also cover briefly here. It's difficult to treat, and JAK inhibitors have made a huge difference here. But what are we missing in terms of therapy that is based on the pathobiology principles that we will try to understand together? Now, the diagnosis is easy. There's a pathognomonic skin and hair phenotype that you can particularly well identify if you use your dermatoscope. On the right-hand side, the beard focal areata that the naked eye could easily have missed is immediately visible in the dermatoscope. You see these white hair shafts popping up in a patch of normal appearing alopecic skin. That no other disease does that. You see that, you have a diagnosis. You can also diagnose cadaver and exclamation hairs, as you know. The regrowth of white hair, poliosis, is another telltale sign. And the skin has to look completely normal. Otherwise, you've got to be suspicious that alopecia areata may not be the right diagnosis here. Why is alopecia areata a hair cycling disorder? Well, first of all, let's remind ourselves that the hair follicle is the only organ in our entire body that for the entire lifespan of the human organism continues to run through a cycle of growth, regression, relative rest, and back to growth. No other organ does that. And it begins this cycle already in utero. So the hair follicle has just finished development in fetal life. It already starts entering into its cycle and sheds its first test hair shaft, the lanugo hair, into its environment. And this cycle, anagen, the growth phase, to catagen, the regression phase, and apoptosis-driven regression phase, and organ involution, back to telogen, and then back into anagen, that is severely disturbed in alopecia areata. It's a hair cycling disorder in a dual sense. The perifollicular inflammatory cell infiltrates that move in on the hair bulb down here around the anagen hair follicle only attack when anagen hair follicle. So only when the hair follicle is growing and makes pigment, then it is attacked by inflammatory cells. And this attack leads primarily via a massive increase in gamma interferon, the key pathogenic cytokine in alopecia areata, to catapulting the hair follicle into its regression phase, catagen. That happens only when the hair follicle undergoes collapse of its immune privilege. That then has as a consequence that the hair follicle becomes, on the one hand, dystrophic, damaged, and because gamma interferon is quite cytotoxic, and on the other, the hair follicle goes into catagen, and the hair shaft is shed either during catagen or already, if the damage by gamma interferon is strong enough, during anagen, and the hair shaft is being just shed off. What we also have to assess when we look at alopecia areata patients, as you know, is we have to see how fast is it spreading, how active is the disease, is the pull test of hair shaft in its periphery positive, which is another sign of positivity. Is there ophiasis hair loss, occipital hair loss between the ears, are eyebrows, eyelashes, nails affected? Is the patient atopic? All of those are indicators that the prognosis is here worse. Nail changes are important to look at. And again, you use your dermatoscope because there are only very few diseases in dermatology that show nail pitting, and alopecia areata is one of them. And if you find nail pitting together with these telltale focal signs of alopecia, you have your diagnosis. Alopecia areata comes in variants. The classical one is the focal, multifocal alopecia areata, which can spread into an alopecia areata totalis or even universalis. But sometimes, as in this patient here on this photo, it can present as a diffuse variant. And it's also called an alopecia areata incognita because it has been missed. It will not be missed if you use your dermatoscope, because then you will see very similar signs as we saw before in the beard of the father. Now, overnight graying, probably in many patients where this has been carefully documented, does represent a form of diffuse alopecia areata where only pigmented hair follicles are being attacked, which then shed their hair shafts, and thus demasking the already pre-existing white hair shafts. Now, Ikeda in the 1960s in Kyoto was so fascinated by these different types of alopecia areata that he actually classified them into 4 different subtypes, which the field has not accepted. But I think we have to come back to this Ikeda classification and rethink on the basis of the concept that I'm trying to sell you, that there is an autoimmune type of alopecia areata and an autoinflammatory, non-classical autoimmune type of areata. I think we have to look back very carefully at what Professor Ikeda had to teach us in the 60s. So this is what we proposed, that alopecia areata is not a single disease entity, but a stereotypic hair loss response pattern to a specific kind of inflammatory hair follicle damage that even the healthiest of anagen hair follicles will show even if you have no genetic predisposition to the disease. But, and that's the important but, this will only occur if and when the physiological hair follicle immune privilege collapses during anagen, and, so that alone is not enough, and if this attracts an inflammatory infiltrator, then secretes so much gamma interferon that major hair follicle damage and premature catagen induction occur, and in only some of these patients. This inflammatory infiltrate will represent a genuine autoantigen-specific autoimmune disease that I would call now AAA. So this disease that you see in front of you is not always an autoimmune disease, but always indicates and requires collapse of the hair follicle immune privilege. That is so important because if there's no collapse of the immunological cocoon that the hair follicle builds around itself under physiological circumstances to prevent an attack on its own immune system, on its own structure, you cannot get the disease. And you will only regrow hair shafts and then retain those hair shafts and not get attacked again after you discontinue medication if your follicles have managed to re-establish the hair follicle immune privilege. So what the hell is this immune privilege? Now, the dermatologists among you will be very familiar with the phenomenon of follicular repigmentation of vitiligo, an autoimmune disease that has many pathological similarities to alopecia areata. One of my colleagues actually loves to tease me by calling alopecia areata vitiligo of the hair follicle. I think he's wrong about this, but it's a very nice comparison. And what you see that in this repigmentation, melanocytes keep crawling out of the hair follicle where they have been protected from immune attack that their epidermal colleagues succumbed to. That already shows that human hair follicles have something about their hair follicles that generates a protective environment. And not only for melanocytes, but here you see it in this clinical phenomenon most strikingly. Now, this immune privilege is not only restricted to the hair bulb, but exists also in the hair bulge up here, where the melanocyte stem cells are located. In this slide, this is shown a bit more. The strongest immune privilege is actually established in the proximal hair follicle, where the inflammatory cell infiltrates attack in alopecia areata. But up here, this immune privilege is very important because if you lose your stem cells, you are in deep trouble. Your follicles will get destroyed because when the follicle loses its stem cells, it can no longer regenerate itself continuously through the hair cycle, and you will get scarring alopecia. So human hair follicle melanocytes actually do live a life of immune privilege, and this immune privilege is the key reason why melanocytes in the hair follicle and their progenitors are least likely to get attacked. So let's finally get into a bit more detail of what is this immune privilege of the hair follicle. What is important to understand is that the distal part of your hair follicle, up here, from above the bulge, the stem cell area, where the pili muscle inserts, is a normal immunocompetent epithelium, just as the epidermis. You have the same cells in there, the same mechanisms of immune responses, perfectly immunocompetent. This is also the region where you have the highest density of hair follicle-associated microbiota. But then there is something like an invisible immunological watershed just above the stem cell region, the bulge, below which the entire hair follicle epithelium, not necessarily the mesenchyme, the fibroblasts around the follicle, is immunoprivileged. What is that based on? Now, immune privilege, none of us would be here if we hadn't been immunoprivileged as during fetal life, because we used to be a fetal allotransplant. We were presenting alloantigens, paternal alloantigens to the immune system of our mother, and yet we were not immune rejected, as we should have been, because the fetal trophoblast creates an immune privilege that protects the fetus from being rejected by the mother's immune system. And exactly the same system is being utilized by the hair follicle, and with minor variations here and there, so does the brain, the anterior eye chamber, the testes, and very few other organs, including, for example, the proximal nail fold of your nail apparatus, which also is immune privileged. And the principles are always the same. The principle of immune privilege consists of downregulating antigen-presenting antigens, so-called MHC class 1 antigens and associated beta-2 microglobulin, to prevent that autoantigens can even be presented to CD8 T cells, the cytotoxic T cells that are primed, whose main task is to recognize MHC class 1 presented autoantigens or viral or tumor antigens. In addition, antigen presentation, even by Langerhans cells, is impaired in these immune privileged areas. So MHC class 1 is not even expressed in functional levels on Langerhans cells in the hair follicle below this immunological watershed. And there are many other different aspects of immune privilege that you find also in other journals, in other organs, that we can find again being established in the hair follicle. The hair follicle even makes its own cortisol, very important immunosuppressive hormone, as you know. It has also established regulatory T cells around it that may contribute together in activities of mast cells around the follicle to creating a profoundly immunoinhibitory, tolerance-promoting immune milieu. And this is what has to get destroyed and severely, at least severely impaired, in order to be even able to get alopecia areata. And these are, on the left-hand side of the slide, you see a couple of other mechanisms, immune privilege mechanisms that other organs, the brain, eye, testes, fetal trophoblast, pancreatic islet cells, also nail matrix, and possibly even the eccrine gland coil established. There are many unanswered questions about this immune privilege. Why does the hair follicle even do this? Well, one is that melanogenesis-associated autoantigens that you expose whenever you are making melanin, and in the hair shaft pigmentation process, when the hair follicle pigmentary unit down here is making massive amounts of melanin, you are exposing a lot of these autoantigens. That this requires an immune privilege, because these melanogenesis-associated autoantigens tend to be highly immunogenic. That's one hypothesis. Another hypothesis that we promoted a couple of years ago is that where maybe actually this immune privileged area is a special device to create peripheral tolerance to autoantigens that have escaped thymic selection. Be that as it may, what happens in alopecia areata is that this entire system collapses. MHC class 1 and 2 molecules get highly upregulated. Out of a sudden, there are all sorts of cells around the follicle that have everything but an immunoinhibitory function. And immune privileged guardians, such as alpha MSH, TGF beta 1 and 2, and IGF-1, that are there to keep this immune privilege intact, all are now only found at very low levels. And mast cells that in physiological life around the hair follicle have an immunoinhibitory phenotype become profoundly pro-inflammatory. There may also be an insufficient immunoinhibitory activity of regulatory T cells around the hair follicle. All of this lead to immune privilege collapse, and the main inducers for this that have been characterized so far are gamma interferon and, interesting, the stress-associated neuropeptide substance P, but not interleukin 2, not interleukin 15, not interleukin 17. Agents that may play some role in alopecia areata, but they certainly don't play a key role because they do not induce hair follicle immune privilege collapse. All that leads to loss of peripheral tolerance against hair follicle-derived autoantigens. Now, where this occurs is actually really, really important. Like in the real estate business, location, location, location is all that counts if it comes to hair follicle immunology. Now, if your inflammatory cells attack the bulge and the stem cells, as I already mentioned briefly earlier, that causes major havoc because it destroys the capacity of the follicle regenerative cells, giving you scarring alopecia such as lichen planopilaris or frontal fibrosing alopecia. If that happens around the bulb down here, damage to the follicle can actually be much larger than the often quite discrete damage in scarring alopecia to the bulge, but the consequences are very different. This does not destroy the hair follicle. You may lose your hair shaft. You may lose every single hair shaft on your body, but you do not lose your hair follicles. So there's always hope. And it's important that you tell your patient that if our drugs to treat this disease become even better, that these follicles, or at least most of them, can be resuscitated to life. They do not die as they do in scarring alopecia. That makes a huge difference. So whether the bulb or the bulge immune privilege collapses has dramatically different clinical consequences, at least not only in phenotype, but also with regard to reversibility of the clinical problem. I said it's a hair cycle disordering in dual sense. Now you get probably a better understanding for what has happened here. MHC class 1 based hair follicle immune privilege has collapsed, and the cells that are capable of recognizing autoantigens presented by MHC class 1, namely autoreactive CD8 T cells, can then attack the hair follicle. But they are not the only ones that can do that. I will come to that in a second, but let me emphasize again that the key cytokine that these CD8 T cells and other NKG2D positive cells, such as natural killer cells, and now we know also gamma delta T cells can secrete in high quantities. That's the key cytokine that induces hair follicle immune privilege collapse and hair follicle damage. This is where JAK inhibitors have come in so impressively because they block signaling through the gamma interferon receptor and thereby antagonize gamma interferon activities, and they may even suppress catagen, possibly because, as we had shown a long time ago, the gamma interferon is actually the strongest catagen promoting cytokine that we know. But there's a little problem with JAK inhibitors, and that is their non-specificity. As you see in this older cartoon, but in essence, this is still the situation that we face today, JAK inhibitors, none of them is fully selective so far, those that are already in the clinic and FDA approved, they also hit many receptor signaling pathways that you really wonder, is it a good thing that we block those? So those that we want to block, because they are clearly important for the inflammatory infiltrate around the hair follicle, are the gamma interferon receptor and also the interleukin-2 receptor, possibly also the interleukin-4 receptor, and maybe even the interleukin-9 receptor, which we most recently found is actually expressed in our hair follicles and whose signaling may inhibit hair growth. So blocking that sounds good. But there may be other receptor signaling events that make me quite uncomfortable with JAK inhibitors that are not selective, and particularly interleukin-10 receptor signaling. Interleukin-10 is one of the key immune privilege guardians that protect the hair follicle immune privilege and that you need in order to maintain your hair follicle immune privilege. Prolactin receptor. Now, prolactin, we showed earlier that in female scalp hair follicles, you need to actually stimulate it to keep the hair follicle growing. And moreover, you need your stem cells in the bulge need signaling through this receptor in order to stay happy and alive. And the same may be true for the erythropoietin receptor in our hair follicle, which protects the follicle from apoptosis. And most recent data that we're just working on now, the interleukin-15 receptor, at least in the hair follicle, not on the inflammatory cell infiltrate cells, where you want to block its activity, but on the hair follicle, expressed in the hair follicle epithelium, gamma interleukin-15 receptor signaling may actually be required for keeping the hair follicle in anagen, and may even protect the immune privilege of the hair follicle by mitigating the negative effect of gamma interferon. So what we can say that the currently used JAK inhibitors in clinical practice in alopecia areata, from a pathobiology point of view, are too non-specific. And we need to develop agents that target particularly the interferon gamma receptor and maybe the interleukin-2 receptor, maybe a few other ones, but not so much across the board as we are currently doing. We have pointed this out in a little letter in a correspondence in The Lancet. So one needs to be careful. What could be the undesired effect if inhibiting, for example, interleukin-10 signaling? And so I would think that what one would pathobiologically really desire, as long as we don't have more selective JAK inhibitors, that a short-term systemic therapy is all right, then long-term better switch to topical JAK inhibitors. We also need, for example, gamma interferon and interleukin-15 to defend us against a wide range of infections. And do we really want to suppress interleukin-15 signaling? All very unclear. So JAK inhibitors are a most welcome landmark addition to our therapeutic weaponry in the fight against alopecia areata, but they are not yet the holy grail in areata management. What we also would like to understand is, how does this swarm of bees infiltrate, even get to the hair follicle? Now, what we know is that this swarm of bees infiltrate. The characteristic one around the proximal anagen hair bulb consists of NKG2D positive cells, CD8 T cells, natural killer cells, but also, as we know now, gamma delta 1 T cells and ILC 1 cells, innate lymphocytes, and pro-inflammatory mast cells. What do they recognize? Well, once the CD8 positive cells, they probably recognize what they are educated to recognize, namely MHC class 1 presented autoantigens, perhaps melanogenesis associated ones. But all the other ones recognize also, in addition, CD8 T cells can recognize that too via their NKG2D receptor, a danger signal called MIC-A, which NKG2D is activated by. And that then leads to substantial secretion of gamma interferon by these cells. What attracts them there? Well, it could be the autoantigen production itself, the danger signal, overexpression of MICA. We have already shown that this happens. And chemokines are being released. Certain chemokines, particularly CXCL10, is being excessively released, attracting an inflammatory infiltrate, particularly cells that have this NKG2D receptor. So what we can say is that there is no alopecia areata without immune privilege collapse, peripherally inflammatory cell infiltrate, premature catagen induction, anagen hair follicles, and hair follicle dystrophy. And on this basis, we postulated a long time ago that alopecia areata is a CD8 T-cell dependent autoimmune response against melanogenesis-related autoantigens that are exposed during anagen by abnormally high MHC class 1 expression in an anagen hair bulb whose immune privilege is collapsed. And in subsequent years, a lot of experimental evidence for this theory has been provided, and it's now the accepted main alopecia areata pathobiology hypothesis. But how antigen-specific is alopecia areata really? Do we always face a CD8 T cell dependent autoimmune disease when we see alopecia areata hair loss phenotype in front of us? And is a specific genetic predisposition really required to develop alopecia areata? Well, the answer is no, no, no. There are two main lines of evidence. Well, the swarm of bees infiltrate in human Alopecia areata contains also many, presumably, autoantigen specific innate transitional immunity protagonists. For example, mast cells. We now know innate lymphocytes, ILC cells. That paper got already published. It's an older slide. And as we recently published, also gamma delta T cells. In normal scalp skin, you don't have hardly any natural killer cells, but around alopecia areata lesions, they increase dramatically in number. And what also increases in these cells is massive expression of MIG-A, this danger signal that you only find in a healthy hair follicle, if you find it at all, in the most proximal tip of the hair bulb, which may be the immunological Achilles heel of our hair follicles. It may also explain why the inflammatory infiltrate in areata preferentially and almost only there, except attacks the proximal hair bulb. So non-specific, non-antigen specific natural killer cells activating receptor, they express NKG2D and its ligands such as MIG-A are very important in alopecia areata pathogenesis, which was independently confirmed in a famous GWAS study that NKG that showed that the most strongly alopecia areata associated genes were actually ligands that activate NKG2D. To me, the strongest line of evidence comes from this functional experiment. My dear colleague and friend Amos Gila in Haifa, Israel, has developed a wonderful humanized mouse model of alopecia areata, where he takes normal, healthy human scalp skin from an individual that has no history of alopecia areata, no family history even, transplants it on a skid mouse, an immunocompromised mouse, then takes autologous peripheral blood monocytes that have been selected for NKG2D, a natural killer cell, containing cell populations that have been in vitro pre-stimulated with interleukin, a high dose of interleukin-2, which activates these cells. And then he injects these autologous cells into the patient's own skin, now on the mouse, and he can induce a complete phenocopy of alopecia areata that is clinically and histologically indistinguishable from the real human disease, probably as a result of a cytokine storm of gamma interferon being released by these natural killer cells. So that's functional evidence that natural killer cells alone suffice, and that you do not need a genetic predisposition for the disease, and that you do not necessarily have to have an autoantigen and autoreactive CD8 T cell driven disease when you see alopecia areata in front of you. These are dispensable for the hair loss phenotype that we diagnose as alopecia areata. Moreover, we found that V delta 1 gamma delta T cells, which are also certainly not classical autoantigen recognizing cells, they may be recognizing some autoantigens, but normally what they recognize is stress signals, danger signals. And again, it's a gamma interferon that they secrete. And what I found particularly interesting is that the number of these gamma delta T cells around hair follicles is already increased in non-lesional skin of alopecia areata patients, which tells us that their increase is a very early event. And then these cells in an established lesion actually invade into the follicle epithelium, just like CD8 T cells do in areata. And again, you can, in Amos Gilha's wonderful humanized mouse model of areata, induce hair loss lesions just by injecting these gamma delta T cells or innate lymphocytes, ILC1 cells. This we haven't published yet. And it can also be prevented by regulatory NKT cells, immune inhibitory NKT cells that secrete interleukin 10. One more reason why you don't want to suppress that. And interestingly, we're now looking at, is it actually interleukin 15 that keeps this alopecia areata preventive cell population of inhibitory NKT cells happy and active. One more reason why you don't necessarily want to inhibit interleukin-15 signaling with broad-based JAK inhibitors. What do these gamma delta T cells do around the hair follicle? So our current working hypothesis is that they are a kind of surveillance police that in low numbers scan your skin and its hair follicles and check, is there anyone out here expressing danger signals that we can recognize via our NKG2D receptor, namely MIG-A. And when they then, under normal circumstances, nothing happens. There's low expression of MIG-A. The gamma delta T cells comes and goes again. But when your immune privilege gets threatened or weakened, and the follicle is somehow damaged, it will express this danger signal. Then the surveillance police, the gamma delta T cells, that's our theory, as it has already been described very beautifully in mouse systems. Then they get really activated. They start secreting gamma interferon in large quantities. They call in additional immunocytes that assume a pathogenic role, but primarily they cause further immune privilege collapse, and that's how they initiate, according to our current understanding and hypothesis, this alopecia areata response pattern in an autoantigen independent manner. So in future alopecia areata therapy, what we want to do is we want to de-stress hair follicles. We want to downregulate MIG-A expression and the excessive secretion of chemokines that call in more troops. We want to have drugs that downregulate, for example, CXCL10 secretion. And what we need to keep in mind is that our bulb, hair follicle immune privilege, whose collapse lies at the basis of alopecia areata pathobiology, is continuously under threat. Now, there's always some stress pull on your head's trauma, hypoxia, excessive reactive oxidant species production, for example, during melanogenesis, where a lot of reactive oxidant species are being produced, could all in principle lead to excessive MIG-A expression and chemokine release. And in organ cultured, microdissected human scalp hair follicles, we've already proven that this happens. This then can activate natural killer cells, gamma delta T cells, gamma interferon release occurs, and boom, you get immune privilege collapse. Also, the hair follicle microbiome itself could, when there's a dysbiosis, lead, for example, to excessive chemokine release, or which then attracts gamma interferon secreting cells such as gamma delta T cells, innate lymphocytes, and CD8 T cells. Psychoemotional stress even can threaten your immune privilege, because we already showed that the key stress-associated neuropeptide, substance P, is a very potent inducer of hair follicle immune privilege collapse in your scalp hair follicles. And there could be ectopic expression of autoantigens. For example, when a stressed hair follicle enters into pigment production during anagen, as it should, that's its job, that could, if you are among those individuals that are unlucky enough to have autoreactive CD8 T cells that recognize those melanogenesis-associated autoantigens that your hair follicle makes during anagen, then you can get into trouble. And there could be loss of peripheral tolerance that also threatens the bulge immune privilege. So our new concept here is alopecia areata is not one disease, and that some forms of alopecia areata may not even be a disease at all, but just a response pattern. So the hypothesis is this: only in some areata patients, this response pattern occurs because they have autoreactive interferon gamma secreting CD8 T cells that recognize antigen-associated, hair follicle-associated autoantigen, a classical autoimmune alopecia areata constellation, AAA, which comes back to my original 1990s hypothesis. In those patients that have frequently relapsing episodes, have other associated autoimmune diseases, the likelihood that they will have autoimmune areata, in the old Ikeda classification, it would have been type 4 areata. In these patients, a causal and curative therapy will ever only become possible if we identify finally the still unknown autoantigen. Is it really a melanogenesis associated one? Is it something else? It's got to be something that is only expressed in antigen, but that's basically all we know so far. If we restore peripheral tolerance against that autoantigen, and if we just eliminate the autoreactive T cells. So in other Areata patients, and it may even be the majority, the type 1 Areata patient that Ikeda was talking about, we claim now there is no autoantigen-specific hair follicle autoimmunity. So this we perhaps should better address as autoinflammatory areata. Instead, what you do have here, as in the autoimmune variant, gamma interferon storm, massive release by natural killer cells, gamma delta T cells, ILC1 cells, and maybe yet some other cells we have not discovered yet. For example, after trauma, stress, infection, hair follicle dysbiosis, we don't know really yet how this is triggered. And or by stress-induced substance P-dependent neurogenic inflammation. Here, all you need is very symptomatic therapy, because the follicle, once you abrogate this gamma interferon storm, will restore itself, its own immune privilege. And many patients that have spontaneous recovery of alopecia areata may fall into this category. Here, we are not treating a disease. Here we are treating, in this subtype, the autoinflammatory alopecia areata subtype that I'm postulating, we are just treating a response pattern, not a disease. So both forms, however, that's important to keep in mind in our overall context of hair follicle clinical immunopathobiology, show the alopecia areata quartet, namely perifollicular infiltrate. Without that, you never get alopecia areata. Immune privilege collapse, no areata without immune privilege collapse, and no lasting hair growth either without immune privilege restoration, hair follicle dystrophy, and premature catagen. Targeting these four always makes therapeutically complete sense, no matter whether we are talking about the autoimmune areata or autoinflammatory variant. So restoring hair follicle immune privilege and de-stressing hair follicles, inhibiting catagen, and repairing hair follicle damage, that's what we must get much more effective. So my personal drug wish list that April 2021 would contain the following. I would love to have topically effective JAK inhibitors that do not target, for example, interleukin-10 receptor and prolactin receptor signaling, but may inhibit interleukin-9 receptor signaling if it really gets confirmed that interleukin-9 is hair growth inhibitory. What we want, ideally selective, topically applicable gamma interferon receptor antagonists, and topically effective tacrolimus, because we had already shown in many years ago that tacrolimus is indeed very, very effective in restoring hair follicle immune privilege and preventing its collapse. So it's not only preventive, but also therapeutic. The same can be said for alpha MSH, and we have for the longest time tried to check whether alpha melanotide, a long-lasting analog of alpha MSH, is effective in alopecia areata, but have failed to convince the company that sells it to engage in this. But alpha MSH, I think, is a very, very attractive areata protective and therapeutic agent, because it's one of the immune privilege guardians of the hair follicle. And systemic substance P receptor antagonists also deserve to be looked at. So what we really want as a new class of agents in this disease is topically effective upregulators of endogenous hair follicle immune privilege guardians, this long list at the bottom, and topically effective downregulators of hair follicle distress signals such as MIC-A as well as NKG2D antagonists. Now, with this, I think I've tried hard to convince you. What we need to do in Areata is we need to restore immune privilege, and we need to control this hair follicle cycling disorder with its premature induction of catagen. And if we do that, we will automatically also deal with the hair shaft defects that arise in Areata. With that, I think you hopefully now can answer these questions. What is so special about the hair follicle? Why immune privilege collapse, hair follicle dystrophy, and premature catagen are critical? Which therapeutic interventions are most promising? Why Areata is what you see is only a stereotypic response pattern, and doesn't tell you whether it started as an autoimmune disease or just as an autoinflammatory disorder, and why we need a much more personalized medicine approach to future management of our Areata patients, where we can hopefully one day distinguish between these subtypes. And finally, I hope next time you look at alopecia areata, you will agree with me that this is not only one of the most common human autoimmune and autoinflammatory diseases, but also one of the most fascinating ones which holds numerous immunology lessons in store that you can apply to other areas of medicine, and that you beautifully can and exemplary study in this disease novel pharmacological intervention strategies. Thank you very much.